Welcome. Good evening. My name is Nemeth, and I'm one of the vice chairs of the Europe region of World Physiotherapy. This webinar is a follow-up of the webinar the Advocacy and EU Matters Working Group hosted in 2022. The Advocacy and EU Matters Working Group is one of the 3 permanent European region working groups. The others are the Research and Education Matters Working Group and the Professional Practice Working Group. You can find previous webinars hosted by these working groups on our organization's website. Also, Esther Mary Darcy, the chair of the region, wanted me to say hello to each and every one of you on her behalf, because she couldn't be present here tonight. She's on her way to present at the conference of our Italian colleagues. This evening's webinar will dive into the important aspect of primary care. Assuring a rightful place for physiotherapists in the primary care professional team is one of the Europe region's priorities. That is why the region is involved in the European Forum for Primary Care, as we do believe that physiotherapists should be included in primary care in the country's healthcare systems. The primary care topic touches the scope of other Europe region's working groups. And where the issue is linked to the practice organization, this will be treated by our colleagues from the Professional Practice Working Group. The scope of this evening's webinar on primary care will mostly be on advocacy and policy aspect, with an understandable sidestep towards practice, as we cannot detach one from the other. In this webinar, you will be hearing examples from colleagues across Europe, as they will be talking on how primary care is organized in their country. You will hear if and how physiotherapy is included in primary care and what the perceived obstacles are for physiotherapists. And I wish to acknowledge and thank the colleagues from our member organizations who are willing to share their testimonial with you this evening. In this webinar, you will hear from Apnori, from the Kosovo Chamber of Physiotherapists, Fran, from the Irish Society of Chartered Physiotherapists, and Gunnlaugur from the Icelandic Physiotherapy Association. I thank the Advocacy and EU Matters Working Group, and I leave you all in the capable hands of Līva and Adérito, who will lead this evening's webinar. Enjoy.
Good evening, colleagues, and thank you, Tim, for the introduction. We continue with the second webinar about the physiotherapy in primary healthcare, and I think we can continue next year about this topic as well, and go just further with it. Before we jump into the excellent presentations, there are some technical details for you to actively participate in the webinar. First of all, you already maybe read. If you have any questions, you can write them in the Q&A section that you find. We will have time for the questions, but we will do it after all of the presentations in the discussion part. So if you don't hear your question right after the presentation, just be a bit patient. We will come back to that. The webinar will be recorded, and it will be placed in the region's YouTube channel afterwards. As I mentioned, the discussion part will be at the end of the webinar. So if you would like to join in the discussion, you have to raise your hand, and we will put you in the panelists, so you can ask your question and actively participate. Well, I hope that technically we are safe, and I hope that you will ask the questions and come with the feedback. We will open this webinar with the overview on the physiotherapy in primary healthcare in Europe, and these will be results from the survey that the working group did this year. For this, I'll give the floor to Adérito, and he will talk closer about the results we got.
Good evening to all of you. My name is Adérito, and I will be presenting the preliminary results of a survey that the Advocacy and EU Matters Working Group has issued this year. During our last year's webinar on physiotherapy in primary healthcare, it became clear that information on the state of physiotherapy in primary healthcare in the European region was lacking. Therefore, one of the projects of our working group in the current term is trying to provide information on this knowledge gap, which can be important for member organizations, but also for the region to plan future activities. Trying to capture the most accurate picture of the current state of physiotherapy in Europe, in primary healthcare, the survey was sent not only to member organizations, but also two additional organizations that are not currently members of the European region. So in total, we have sent 40 surveys and we received 37 answers, which is a 93% participation rate, which is quite good. Our first question was if primary healthcare was part of the public health system, and all respondents, and we had 37 answers, answered yes to this question. The second question was whether physiotherapists are legally included in primary healthcare in the public healthcare system. Here, 27 member organizations have answered yes, and 10 organizations have answered no. As in the private healthcare systems, 25 organizations have answered yes, and 11 have answered no. One of the respondents answered that there is no private healthcare system in the country. Looking into the reality, there are countries where physiotherapy is included in primary healthcare in the public and in the private system, countries where physiotherapy is included in the public system but not in the private system, and vice versa, and countries where physiotherapy is not included in any of the systems. It is quite an heterogeneous scenario. The details are presented here. So in 24 countries, physiotherapy in primary healthcare is part of the public and private healthcare systems. In 6 countries, physiotherapy is not included in the public or private healthcare systems. In 4 countries, it is included in the public healthcare system only, and in 3 countries, it is included in private healthcare system only. Considering the information regarding the inclusion of physiotherapy in public healthcare system, 27 organizations have answered affirmatively to this question. However, when asked how many physiotherapists are working in primary healthcare in the public healthcare system, only 21 provided a number. Only 21 were able to provide a number. And only in 5 of these cases, the number provided was from an official source. Regarding the number of physiotherapists provided in the organization, it represented between 0.1% and 100% of the number of physiotherapists reported in the country profile from the Europe Region World Physiotherapy website or the World Physiotherapy website, which may be a sign that the question may have been interpreted differently by the organizations. The median was 34.9% of the physiotherapists mentioned in the country profile. So 43% of the member organizations reported a number below 20% of physiotherapists in the country profile, and 33% of the member organizations reported a number below 10% of the physiotherapists in the country profile. Regarding the inclusion of physiotherapy in private primary healthcare system, 25 organizations have answered affirmatively to the question. However, when asked the number of physiotherapists working in private healthcare system, only 19 provided a number, and only in 4 of the cases, the number was provided from an official source. Regarding the number of physiotherapists provided by organization, it was representing between 0.5% and 100% of the number of physiotherapists in the country profiles. The median was a little bit higher, 43.1%. So 21% of the member organizations reported a number below 20% of the physiotherapists in the country profile, and 11% reported a number below 10% of the physiotherapists in the country profile. When asked if medical referral is required before a physiotherapist can engage with a patient in primary healthcare, we have different amount of, we didn't have 37 answers here because 6 member organizations stated that physiotherapy in primary healthcare was not part of the public or private healthcare system. So we have only 31 answers here. And we can see that 39% answer that yes, it is required at all times before a physiotherapist can engage with a patient. 42% answered that it is required in specific situations, and 19% stated that it is never required before a physiotherapist can engage with a patient. We talked about specific situations, and the specific situations that were most reported were when not in the scope of prevention. So whenever the aim was not doing prevention, referral was needed. If it is in the public system, but not in the private, referrals were not needed, and for reimbursement purposes, especially in the private system. When asked if physiotherapy is if the countries answered that it was no, so no referral is needed, they were asked if how patients were referred to physiotherapists in primary healthcare. So we have one organization stating that medical doctors or other health professionals can refer patients to physiotherapy. One country referring that medical doctors and other healthcare professionals can refer to physiotherapy. Patients can always refer themselves to physiotherapy was provided by one organization, and 3 organizations have not provided an answer to this question. When asked if physiotherapist is legally authorized to assess or diagnose as part of treatment in primary healthcare, we have 13% of the organizations stating that they cannot assess and diagnose, 45% of the organizations stating that they can assess and diagnose, 26% of the organizations stating that they can assess but not diagnose, and we have 16% of the organizations stating that they can assess, but they didn't provide an answer regarding if it is possible or not to diagnose patients. When asked if physiotherapists are legally authorized to define a treatment plan in primary healthcare, the majority of the organizations, so we have 29 answers stating that yes, they can, and only 2 stating that they were not able to do this. Looking into referral, we have this series of questions were questions that member organizations skipped answers a lot. So if, as you can see, we have a lot of organizations that haven't provided an answer, but in short, we have 4 member organizations stating yes to 3 of the questions, 2 member organizations stating yes to 1 and no to other 4 questions, 7 member organizations answering no to all the 5 questions, 1 member organization answering no to 1 question and not answering the other 4, and 17 organizations not answering to any of the questions. But here we asked if physiotherapists were able to refer to a general practitioner, medical specialist, other health professionals, if they can refer to X-ray or other diagnostic tests. Then we tried to understand what activities were performed by physiotherapists in primary healthcare, and we provided some choices, as you can see here. So all respondents stated that they could treat patients one-on-one. 94% of the countries stated that they used education for patients and caregivers. 90% stated that they could use prevention and management of chronic conditions in the community. 81% reported being involved in fall prevention activities, and 39% in screening and diagnosis as first contact practitioners. Then we have other specified activities that they were able to provide as well, such as research, clinical government tasks for physiotherapists in management roles, bandaging, palliative care, planning, home-based interventions, consultancy. So a lot of activities also reported additionally. We also try to understand if there were specific academic or professional education for physiotherapists working in primary health care. And from the answers that we received, we have 27% of the answers saying that yes, that there was specific academic or professional education. They mentioned post-graduations, even the bachelor was also something that some member organizations reported. Then we have 59% stating that no, there is no specific education for physiotherapists working in primary health care, and 14% of the answers were not available. We also tried to assess satisfaction with autonomy of physiotherapy in primary health care, and this is the distribution of the answers that we obtained. So we have a minimum of 0, a maximum of 10 in a scale from 0 to 10. So a lot of answers on 0s, on 5, and on 8, and some answers on 10 and other values as well. But when we try to cross this information with other factors, for instance, if physiotherapists are able or are included in public healthcare system or included in private healthcare system, or if they can assess or if they can diagnose, and if a referral is needed, we see that these factors seem to be related or important to satisfaction with autonomy in primary healthcare, especially when we look into factors such as if physiotherapists are included in public healthcare system doing in primary healthcare, and if they are able or not to do a diagnosis in their activities in primary healthcare. As final remarks, of course, we have to acknowledge some limitations. First, the language barrier. The survey was conducted in English, which is not the first language of the majority of the member organizations. And we have also the individual respondent bias, which may not be indicative of the national picture. So this was the first survey on physiotherapy in primary healthcare systems, providing a baseline on data that we should address in the future. The elements, the results of the survey will allow the region and the member organizations to reflect on the addressed elements and the possibility to request for assistance of the region if desired, for instance. Furthermore, the data of the survey can be used by the region itself to explore possible advocacy initiatives for physiotherapy in primary healthcare in the European region. So we should continue to follow up on this data, and we should also try to tune some of the elements of the survey that, after data analysis, we believe that we might have to do so as well. But I think the information is important for us to understand a little bit more of what's happening on Europe, and to plan the next webinar of the working group. Well, thank you.
I think this is a very good beginning where we start with. That's why we came up with the idea to share the country experiences, because that's one of the points where we can get some ideas, some points, or I don't know, key messages, what we can do in our own country to make it better, or to make it the way we would like it to be. Okay, so we will continue with the country experiences, and the first one I will invite Fran from Ireland. She's the Professional Practice and Membership Engagement Officer in Irish Society of Chartered Physiotherapists.
Thank you very much for inviting Ireland to present. So my name is Fran, and I am currently the Professional Practice and Membership Engagement Officer, and as of the end of the month will be the Professional Advisor for the ISCP. So I'm a physiotherapist myself by training. I don't sound very Irish, so this is not how we sound in Ireland. I'm originally from South Africa, so I qualified and worked in South Africa, and I've been living in Ireland for 7 years now, and I've worked for the ISCP for 4 years. So this is just, the ISCP, like all the other member organizations who belong to the Europe region of World Physiotherapy. We're the member organization representing physiotherapists in Ireland. The three key areas, and I'm hoping that I'm going to kind of give some information on, it was really great seeing the survey results, so thank you for presenting those, and I'm hoping that I will kind of answer the questions that have been presented to us. So I'm going to be looking at, the organization of physiotherapists, physiotherapy services within primary care, the role of physio, and the evolution of physio and how it's changed within the primary healthcare system within Ireland. Some of these I've set them up as 3 different sections as we go through the presentation, but there is a little bit of overlap. So when I'm talking about the referral in, some of the systems are relatively new, and I'll so some of the evolution, discussion will almost come into some of the other areas of the presentation as well. So within Ireland, in terms of the organisation of the setup, we do have a mixed healthcare system. So we have both a public and a private healthcare system. The public healthcare system is supported by the state, and many public services are free of charge. We do not have a universal healthcare system though. So while public services are free of charge, the government in more recent years very much led from the COVID pandemic and introducing supports to help people through the crisis. We used to have in-hospital charges; those have now been dropped. So most public services, once you're within the public healthcare system, it will be free of charge. The Health Service Executive, which is a public health service, is responsible for the delivery of the public services, and the HSE will provide these directly, or they will provide funds to other organizations to provide these services on their behalf. We then have a very big private healthcare system as well, and this is provided by individual health professionals, and it will range across, our GPs, our consultants, HSCPs, so health and social care professionals. The services are usually paid by the patient or the service user. They will pay the full cost, and they may be covered by private health insurance to be able to recoup some of that cost. As I mentioned, there's no universal primary care cover. So if you want to see a general practitioner within primary care, then patients do need to pay for that themselves, except there are 2 situations in when patients don't need to pay to see a GP. That's if they've got a medical card. So about 34% of our population qualify for a medical card, and that's if their income is below a certain level. And then this will include, they then don't pay for any costs. So it will include seeing a GP. It will eliminate all public hospital services, like costs. So everything is free for them, but it doesn't cover any services provided by private healthcare. So it is a medical card which will cover them within the public system. And then if you don't qualify for a medical card, you might qualify for a GP card. And that will then cover you for your free visits to the GP. A GP card is available for everyone under the age of 6 and everyone over the age of 70. So if you don't have a medical card or a GP card, you will pay to see the GP. And then most of your other services, once you're in the healthcare system, public healthcare system, would be free at the point of service. In terms of our private and our public physiotherapists, so we'll start with private. Our private physiotherapists, patients can refer themselves indirectly. They do not need to be referred. They can also be referred by a GP or a consultant. They would have a say, the patient would have a say as to who they may wish to go to, but the GP or the consultant would have good relationships with certain private physiotherapists and would then refer them. But if a patient could also request and say, well, I'd like to go to X, Y, and Z, and the consultant or the GP would then, facilitate and refer them to them. But they can also just go, they can be self-referred. The patient will cover the cost at the time of the service. And as I mentioned, they may be reimbursed by the health insurer. The only requirement there is that the person is regulated. So that would be the regulator of physiotherapists. So to work as a physiotherapist in Ireland, you need to be on the CORU register. It's the regulator, and provided there is a CORU number on the invoice or the receipt, then the health insurer will reimburse a percentage back to the patient, depending on what plan they might be on. Within private physiotherapists can refer for certain diagnostic tests. So we can refer for MRIs and other kind of imaging. The one thing that we can't refer for, whether it's public or private, is in Ireland, we actually can't refer for X-ray, for ionizing radiation. It's an area that the ISCP is advocating on, and we should see changes. It was promised this year. We're running out of time this year, so hopefully by next year, physiotherapists should be able to refer for X-ray. So physiotherapists within privates are autonomous, so they can access, they can diagnose, they can treat, they can refer on. So they manage the patient care, and we have physios but working both within public and private who would be working at a very advanced scope of practice, working in advanced physiotherapy practice roles, always clinical specialists of that. So then the difference within the public healthcare system is the public physios, so you can be referred in by a GP, a public health nurse, by another health and social care professional, so by an OT, a dietitian, speech and language. We've got 26 HSCPs, so they can refer in for physio. You can be referred by a consultant. You can self-refer into the public system, but it tends to be quite low nationally. A referral by a GP or a public health nurse is more kind of the main kind of referral source. There are different systems for delivering care, and I'll kind of get into a little bit more on some of the next slide. Some services will require a medical card. So this is something that is decreasing, but previously patients, in terms of just because there was such a demand for care, the public health service was kind of taking those with a medical card. And if you didn't have a medical card, you needed to go privately. And that was really just to try and reduce waiting times and reduce the patient flow. So that is now kind of generally being taken out of the system, but some services may prioritize people with a medical card over someone who doesn't, because they could access private healthcare if they needed to. As I mentioned, there's no cost to attend the public. And once you're in with a public physiotherapist, they are autonomous physios. So again, they can access, they can diagnose, they can treat, and they can refer on if they deem it appropriate. Sorry, there we go. So this is a little bit of a busy slide, so I hope I can talk you through it. So this was just to show, and this is where some of these things are relatively new. So just in terms of kind of, the last question of how have we evolved, or how has primary healthcare changed within the public system. We would have, you can be referred into kind of like this chronic disease hubs. So we have 4 main areas of chronic disease: cardiology, respiratory, which is broken down into COPD and asthma, and diabetes. So if a patient gets seen by a GP or consultant and they fall into one of these kind of 4 categories, they'll be referred into these integrated care kind of pathways. So a GP or a consultant will refer the patient into, say, the cardiology health integrated care pathway, and then based on their assessment, they may then be referred onto physiotherapy, and the physio would generally be an exercise-based intervention. Again, if a patient has a diagnosis, it has to be a confirmed diagnosis of COPD or asthma. They can be referred into the respiratory integrated care. So they get referred into that integrated care system, and then they will see physiotherapy as part of their holistic approach. And that would tend to involve pulmonary rehab classes and oxygen review clinics, where the physiotherapists would be taking arterial blood gases and reviewing oxygen prescription. We also then have the diabetes, chronic disease, integrated care, but that doesn't have any physiotherapists, which it should. It's led by nursing and podiatry. Then in the middle, we have pediatrics. So everyone under the age of 18 will still fall into peds. If you're under 18 and you have complex needs, which will require a multidisciplinary approach, you get referred into a disability network. And those are, we call them the chronic disability peds networks. And those kind of came about in 2021. Everything else, so every other under 18, if you're complex with a unidisciplinary need, and everything else will just be referred into the general primary care system. So you don't get referred into these kind of like integrated care pathways. Then our other integrated care pathway would be adult services. So there we have, if you are over the age of 75, you have complex multidisciplinary needs, you'll be referred into integrated care for older adults. There is a level of residential care or domiciliary kind of treatment which is provided, but it's not universal around. Every kind of county and location around Ireland will be different depending on the level of care that they will deliver in residential care or domiciliary. So if you don't fall into the integrated care for older adults, you then get referred into the general primary care system, which would be for everyone else. So we have very standardized and structured systems, but at the moment, due to a recruitment crisis and various places, there are a number of positions and vacancies around the country. It kind of, once you get referred into that primary care system, it depends on the staffing levels and the resources as to whether the system can actually accept you. So if you are you get referred with a complex respiratory condition, but you don't have diagnosed COPD or asthma, if the system doesn't have a physio with those skills, the public system can actually refuse that referral, and we'll send that referral back to the consultant to find an appropriate system. And that's really just because we just have a lot of vacancies of physiotherapy posts at the moment. So this is just a little bit of information on those integrated care hubs, which I kind of presented on the other slide. So we have got the integrated care program for children, which is streamlining, and it's kind of taking the multidisciplinary, really complex patients and directing them into our disability networks. Our integrated care programs for chronic diseases, which is covering the 4 main chronic conditions of diabetes, asthma, COPD, and heart failure. And then our integrated care program for patient flow. That's very much kind of works across all of these and is trying to kind of refer the patient to the most appropriate referral system and delivering care as close to home as possible. And then, as I mentioned, we've got the care program for older people. So this, it's physios delivered in a variety of settings. So we've got primary care, we've got community hospices and nursing homes, outpatient clinics, within schools. So it's really varied where the care is provided. Currently, as I say, we've got a wide range of services delivered, a very standardized model, but due to the recruitment crisis and vacant positions, it's not implemented always in a standard way. We do have a high volume of people on waiting lists for the public healthcare system. The highest waiting lists are those with MSK conditions, and our highest risk category would be our children in early intervention and school age, where we have some people waiting for more than a year. 42% of our referrals are in the age group of over 65, and we have identified that there are service gaps that exist. There are some issues with eligibility. Those with non-medical card holders, as I say, some systems were wanting people to have a medical card, but that is definitely more limited now. So the role of PT within primary care. So we would have a number of kind of teams delivering, this is just, we've got our peds disability teams, our adults, and so kind of, again, linking into those, that kind of very busy slide showing you the integrated care pathways and our primary care. This would be kind of how everything there is set up. And really, delivering, a range of different treatments. So physios would be involved in MSK, orthopedics, palliative care, pelvic health, falls, respiratory. So really covering the breadth and depth of kind of physiotherapy services from birth to crossing over the other side. We'd be providing services throughout. I thought this was quite interesting. So this is from 2017, so it is a little while ago, but it was the most recent I could actually find, just in terms of the demand within the public sector, showing that, it is quite a large range, but looking across all the different sites, that our demand for musculoskeletal is between 22 and 70% of the total demand. Orthopedics 1 to 33. Chronic palliative care, some places have no demand and others up to 8%. So this just kind of showed a little bit of the range of kind of the services that people are seeing and the kind of the percentages. I'll just quickly pop back to this slide because I didn't touch on it too much while I was on it, just in terms of the evolution of the system. So primary care, physiotherapists have been involved in primary care since the 1960s with direct access and autonomous referral. The respiratory integrated care was kind of established around 2017, but that has had a big restructure and is now very much kind of a very defined, standardized pathway. Cardiology and diabetes, those integrated care programs were introduced towards the end of 21-22. Our disability networks for pediatrics were introduced in 2021. And then the integrated care for older adults was also in line with the cardiology and respiratory, so also introduced around 21-22. So those have introduced very standardized models of care, but they're still kind of evolving and being developed to their full kind of capacity. So we'll pop back to the end here quickly, sorry. So it's definitely grown. It's grown by key policies. So a big system that was launched in 2017 was called slanted care, which is very much about the delivery of care closer to home. So very much trying to deliver care as close to the person's home as possible and shift the burden from the acute hospitals into our primary and our community care settings. We continue to advocate for the creation of advanced practice. So physiotherapists in Ireland, we don't have an advanced practice grade. We have physiotherapists working at an advanced practice level, and we're trying to get the creation of the actual title and grade for them. As I mentioned, we can't refer for ionizing radiation, and it's an area we're really advocating for. But we do have physios that will take arterial blood gases and can be involved in oxygen prescription. And we're very much advocating that we do need additional staff resources and administrative resources. Some systems within primary community care have very low admin resources, and the physios are spending a lot of time having to complete admin tasks as opposed to being able to see patients. And while we have a great system, which should work if everything was ideal and in place, our services are affected by vacant posts and the recruitment crisis. And that is the end of my presentation. So thank you very much. Thank you for your patience and listening. Thank you.
Thank you, Fran. Thank you for the detailed presentation. I already have some few questions for you prepared, but we will continue, and I will now introduce you with our colleague from Iceland. He represents the Iceland Physiotherapy Association. Gunnlaugur, please.
My name is Gunnlaugur Briem, and I'm the current president of the Icelandic Physiotherapy Association. And I've been serving it in this job for almost 2 years now. And I'm going to try to give you a quick overview of the roles of the physiotherapists in the primary healthcare here in Iceland. And just to start with it, I think it's very interesting to see the situation in Ireland. It's of course a much more populated area, and how advanced it is with the role of physiotherapy. So I might be in contact with you later on, Fran. In general, the whole healthcare system here in Iceland is publicly funded. And even though we talk about the public system and the private system, then we have the private system is mostly funded by the national insurances, which is funded by tax on wages here in Iceland. And I actually just heard like new numbers on the percentage of cost the national insurance is paying for physiotherapy in private practice, and I think it's around 80% of the cost they're paying in what we call the private practice here in Iceland. Just to be clear, then primary healthcare and how we talk about it, it should be accessible community-based healthcare designed to meet the majority of the general health needs. And just to put it into a perspective, then the population here in Iceland is, we are getting close to 400,000 a total. So we don't have a big population, and it reasons into much of our systems. We have, I think, in some ways, more simple systems than bigger countries with regions and things like that. And the majority of the population lives here on the southwest coast. And right now in the capital region, we have 15 primary healthcare clinics. We have 6 mental health teams, and then there's home nursing also within the primary care. And then, like in every other country, we have West Coast and East Coast. And we also have like smaller primary healthcare units out in more rural areas. This was just to give you an overview of the organizational chart of the primary healthcare here in the capital area. And like you can see, and because I decided to be good to you tonight, then I put the English words next to it. Then there is not much about rehabilitation and other service than just doctors and nurses. And there is a special emphasis on mental health right now in the organizational chart, but there is not much about musculoskeletal diseases or anything like that. The role of physiotherapy in primary healthcare here in Iceland is very young. And like you see, it's not big business at this moment. And actually the first physiotherapist that started to work with the primary healthcare clinics in Iceland started in 2011. So it's just 12 years ago. And that person started with in a 15% job percentage. In 2014, they were up to 5 physiotherapists, but still we had 5 physiotherapists with the total of 60% job percentage. In 2016, physiotherapists within the primary care stopped being self-employed contractors, basically. And right now in 2023, we have 26 physiotherapists, but still it's just 6.6 full-time jobs. They're splitting between them. So it's just on 25 on average. And actually they're just recruiting right now. So the first healthcare clinic with a full-time split by 2 physiotherapists is, I think they are recruiting right now. So we are looking into it, looking forward to it, sorry. The role of a physiotherapist in the primary healthcare is to be a first contact or prescribed from another healthcare professional within the primary healthcare. And it's not supposed to be as a long-term or as a treatment option. It's more as a specialist in diagnosis and to educate the patients with problems with musculoskeletal problems. And the 2 main roles our physiotherapists have within the primary healthcare, and this was actually the first role we had, and that is to follow up on the exercise by prescription system. It's when it's prescribed exercise for diseases or symptoms that are known to be significantly affected by regular exercise. Then the physiotherapists go through the medical history, examination, symptoms and things like that, habits and motivation. And with basically make the exercise plan, and usually it's a program of up to 3 to 6 months and maximum of up to 1 year. And it's partially digital, and when patients can basically give information back to the PT on how the exercise plan is going, phone calls and emails and etc. And then the second role of physiotherapists is what we call the musculoskeletal reception. And that is a reception for people with musculoskeletal symptoms. It's supposed to be thought as an early intervention with the aim to prevent symptoms from getting worse and need for other health care, preferably more expensive even. Patients can both come straight to the physiotherapist or referred from another healthcare professional. And first and foremost, education and advice. Follow-up is usually 2 to 3 weeks after the initial contact to the PT. And these physiotherapists in primary healthcare, they can refer patients to self-employed physiotherapists within the national insurance system, which is, like I mentioned earlier, mostly funded by the public insurance and by taxes and wages. And just to give you an overview of it, it's about the reimbursement system here. They actually changed it in 2017, and then they combined a lot of services within the same reimbursement system. So we have specialist doctors, we have physiotherapists, we have some part of service from psychologists, we have some hospital services and other primary healthcare services and imaging. It's all within the same system. So if you pay for specialist doctors, then you might already paid all your part in the reimbursement system, and you could get even physiotherapy for free within that system again. Like I mentioned earlier, GPs and physiotherapists in primary health can refer patients to physiotherapists in private clinics, and they are basically publicly funded for the most. Reimbursement for cost, and we actually got a change again. They've been juggling it around quite a lot because just this January they changed it back to that you don't need the referral from a GP at the primary healthcare clinic to go to a private practitioner physiotherapist. So right now you can go up to 6 times, and it's all with full reimbursement, like if you would get the referral. So they changed it back for us right now in January, and then it had been for 2 years or something that that every patient had to go to the GP to get a referral, and the GPs were complaining about the load of writing out referrals to us. So we could fight for this hand in hand with GPs. If you go into that system, you get 15 times plus additional times if needed and recent. And because there was a question about if you could choose your physiotherapist, and yes, you can choose whichever you want, and you can go between them. And yeah, without any problems, or shouldn't be any problems. Then about the barriers for PTs in primary healthcare. Like I mentioned earlier, we are a young profession within the primary healthcare here in Iceland, and I think we are just on our first steps in our journey to take more space within that sector. Here in Iceland, like I would guess in most other countries, the primary healthcare is historically very focused on both GPs and nursing, and we are trying to fight that. And I think both politicians and primary healthcare CEOs, they agree with us at least to some point. There are barriers about waiting lists to private physiotherapists, and also the shortage of PTs to staff positions, and that has actually been like quite a big barrier for us to open new sectors. It's the shortage of PTs, and when we talk about shortage, then we are still we have quite. I think I was looking at it at Eurostat just a few days ago, and I think we have like 170 to 180 physiotherapists per 100,000 working. So we have a good proportion of physiotherapists here, but there are also many tasks. So we need more. Funding of physiotherapy has historically been mostly through private clinics for the last decades, at least since 1970 something. And actually, when we started getting physiotherapists into the primary healthcare clinics here, that was after like Esther Marie and other good people came here to visit us, and they were so lovely to come and meet with us, with the CEOs of the primary healthcare clinics, and talk about the importance of physiotherapy in primary healthcare. So we are very grateful for that. I hope I answered some questions and hopefully also raised some others. So I'm just going to say thank you for now.
Thank you. I hope you raised some questions for our listeners as well. And we will come back to this at the discussion session. Okay, our last country experience comes from Kosovo. And I introduce you with our colleague Arbnore from Kosovo Chamber of Physiotherapists.
Good evening, everyone. I am Arbnore Ibrahimai Goshi, and I am Vice President of Kosovo Chamber of Physiotherapy. Today, let me introduce you with the organization of the healthcare system in Kosovo, also the role of physiotherapy in this current healthcare system. Healthcare system in Kosovo, it's regulated by the main institution that is Ministry of Health, which makes all the policies and regulations within the system. The healthcare service in Kosovo consists of public, private, and public-private sectors. There are three sectors. Regarding the service levels conducted here in Kosovo, there are primary, secondary, and tertiary healthcare systems according to the current health law in Kosovo. Regarding the primary healthcare in Kosovo, it is totally different from the previous presenters. It's a competence of municipalities here in Kosovo, and they are based on the concept of family medicines, consisting of medicine specialists, family medicine specialists, also nursing, and also in primary healthcare. Primary healthcare is offered also dental healthcare, just in primary level, while in the second level there must be specialists. While in secondary healthcare includes other general and special hospitals, polyclinics and specialistic ambulances, mental health center, physical rehabilitation center, sports medicine, blood transfusion, public health care, and hearing and speech rehabilitation centers. In secondary healthcare system, it's offered, or they provide hospital, outpatient diagnostic, therapeutic rehabilitation, and all other services. Regarding the tertiary healthcare system, here are included university clinical centers, dental, National Institute of Public Health, also National Center of Public Medicine, occupational medicine, sports medicine, blood transfusion, and telemedicine. Also in this tertiary healthcare system, besides other health services, it also provides the education system. It's a faculty of medicine for basic studies, postgraduate studies, and PhD and related scientific research. Regarding the financing tools of healthcare system in Kosovo, this is regulated by the current health law from the budget of Kosovo, budget of municipalities, full payments from the patients, donations, and other incomes from activities. Regarding the role of physiotherapy in healthcare system in Kosovo, as you can see, is included in secondary and tertiary healthcare system. These are public institutions and private clinics, like regional hospitals, university clinical center, and special rehabilitation centers in Kosovo, while private clinics are ambulances that must be licensed by Ministry of Health, so the physiotherapist can practice the profession like an autonomous practitioner. Regarding the referral system to physiotherapy services in public healthcare institutions, there must be medical report, referral from medical doctor or specialist in other fields that should refer the patient to physiotherapy. While in private sector, the patients can self-refer, but not in all cases, because they has to, if they have other funding services, they have to have a medical report or referral from a specialist. Within the University Clinical Center, there are specific units like in all other clinical centers, and there are a number of physiotherapists that are working on these units, and they must coordinate and take the referral from the specialist to access to the patients and apply the physiotherapy treatment. Regarding the possibility to choose a physiotherapist within the public healthcare system, that is not possible because it is not regulated by the current law and the rules of the hospitals. This can be done in private clinics, so they can self-refer to a specific physiotherapist that they would like to. Also, in special rehabilitation centers that are in Kosovo, they are mainly private sector, and there are also referral, and patients are diagnosed from and referred for physiotherapy. And also here, patients can choose their physiotherapist and they can continue with their treatment. As I mentioned previously, the healthcare system is regulated by different forms. In Kosovo, we still don't have regulated the health law, the law for health insurance. We don't have a national health insurance, so we have private health insurance companies that provides this specific insurance, but not all people can do that. In public healthcare system, physiotherapy sessions are done through a co-payment method, where the patients has to pay a minimal cost for their treatment. Otherwise, in private clinic and special rehabilitation centers, there can be the payment can be done by cash or by private health insurance companies, which they need to have referral report from medical doctor or specialist. And there is a specific number of sessions that could be refunded during the year. Also, it depends on the severity of the disease or the problem that the patient has. So the number can be changed. Number of sessions can be changed. As we see during this presentation, you could understand that physiotherapy in healthcare system, in primary healthcare system, it's not yet included. The main barrier for this is the current health law, because it is not currently on it. Also, another barrier that we can mention is the lack of specific education or specialization of physiotherapists in primary healthcare. The profession of physiotherapy in Kosovo has been conducted from the year 2001. So we are a country that we are developing our profession, and we have many obstacles and barriers. In current time, there is a process where the current health law is in the process of the completion of and amendment. So there can be some changes in this time. I have to mention that Kosovo Chamber of Physiotherapy is part of this working group within the Ministry of Health. And we as a chamber advocate for the need and the necessity of the physiotherapy to be included in primary health care, also specialization in different fields for physiotherapy, also in primary health care. This is a process that it's ongoing. I have to mention the support from Mayor of the CPT, from Esther Marie Darcy and Ader, that they are helping us in this process with their presence during this year, with a meeting with our Ministry of Health, also with a recommendation letter where it's described the role of physiotherapy and the role of specialization for improving the quality of healthcare in system, also for patients, and to be in line with European countries. Thank you very much.
Thank you, Arnore, for the presentation. I think it's nice to hear the different experiences and the different way and I can say activity, different level of the physiotherapy included in the healthcare. Then you can understand at what point you are in your own country and where you should go. What can you take from other countries? Thank you very much to all of you for your presentations. I think they gave us the information needed for the further discussion. We heard different experiences, and now maybe colleagues, you have some questions. I know that, and we have one question in the Q&A. It's for Fran. It's about the group sessions. Can you tell a bit more about remuneration for the physiotherapists and the cost for the patients?
Perfect, thank you. So within the public system, the main kind of group classes that we'll be going is a lot with cardiac rehab, pulmonary rehab, those kind of things. Even through COVID pandemic, those transitioned into online classes for patients. So the remuneration, so within public, the patients wouldn't be paying for anything, so they would be covered. And the physio would be doing this within their contracted hours working within the public system. So there wouldn't be any additional remuneration, or that it would be part of the service that they were delivering. So their service may initially be a one-on-one assessment, initial treatment, and then the patient would be kind of directed into a class. And then they would continue kind of with maybe a 6 or a 10 or a 12-week kind of exercise session. Within private, we would have the classes would be a lot more kind of rehabilitation, exercise orientated. We have some physiotherapists working privately within cardiac care, and there the patients would be paying directly, and the physio would be either remunerated per patient, or they would be on a set salary within the clinic, and then that would be forming, the class would just be part of the service that they deliver. So that would be kind of how that was working. I hope that answers the question.
Thank you. Yes, I think if what we'll get some feedback soon.
Yeah.
Adérito, I think you had a question.
Before my question, maybe Birgit can ask her.
Yeah, Birgit joined.
Hello.
Please, so nice to see you.
So, all I wanted to say thank you for all the examples. This is super interesting to hear the different approaches to primary healthcare and where the role of physiotherapists is. I have a question for Fran at this point. So when you said, again, for me to better understand, you said when someone, to see the GP, people would need to pay, but the GP would then refer to a physiotherapist and the service would then be free. Did I understand this correctly?
Yeah, absolutely. So because Ireland doesn't have a universal healthcare cover. So unless you have a medical card or a GP card, if you need to see the GP, you will need to cover that cost. And the GP cost is about 50 euros. That would be kind of the average cost. So there is that stepping stone that every person, so they kind of need to go to the GP and then they could be referred. So some public health systems will take a referral directly, but majority within the public are still looking for a GP or consultant referral. So if the patient is being seen by a consultant within the public system, then they wouldn't be paying for that and they'd be referred. And if they didn't have a GP or a medical card, they would need to pay the GP and then be referred. Within private, they can just go directly. So there is plans within Ireland to roll out universal healthcare that would then provide primary care services for all. But that's we'll have to see where that goes to. But at the moment, yeah, I think it's 34% of the population have a primary card, a medical card, and then we have citizens with a GP card, but we're probably talking at least 50% of our population that doesn't have that, so they would be paying. And our population is now just over 5.5 million, I think it is now. So it is a big percentage that will need to pay for that initial appointment with the GP.
And then, Fran, as you said, there's this entrance fee into the system. But let's say, how is then physiotherapy budgeted? So once you're in the system, you've seen your GP and they refer you to physiotherapy. Is there a limitation? As for example, we heard from Gunnlaugur in Iceland to a certain number of treatments, or how is this kind of limited to make sure that the costs are not exploding in the health system?
Yeah, as far as I know, there is no prescriptive, no defined number of treatments. So it's left to the physiotherapist based on their assessment and their ongoing treatment to make the decision as to when the person needs to come back, do they need to come back, or how they were referred through the system. So patients can continue fairly indefinitely if it's felt that treatment is needed. But where it would be appropriate, they'd be shifted into kind of classes or a lot more kind of rehab, home exercise-based programs. So they would see the physio less and less and less, but there isn't a prescribed number of treatments. Within private, for certain kind of health providers, health insurers will put a defined number of treatments that they would reimburse for. But within the public, it's up to the discretion of the physiotherapist as to how many treatments. Maybe why Ireland has just unfortunately introduced a recruitment embargo, so we can't employ any new staff into the public system.
Okay, so that's
due to finances.
To limit the costs by not offering more positions. This is how you limit your costs. Okay.
Yeah. So now they've done that, but we have, as I say, we have so many vacant positions, and we can't deliver services at the optimal level of where they can. And now we have a recruitment embargo, and that's the way they're limiting costs.
Okay. Thank you. Yeah. Really great.
And Līva, may I come in?
Yes.
Okay, because I have a question for Adérito and for Gunnlaugur, and I will start with Adérito. Thank you for your presentation. I understood that you are currently in an amendment of the health law, and I would like to ask you do you think that following this amendment you will need to change something in education, in bachelor of in physiotherapy, for instance, and to be able to comply with the future needs of the profession in the future landscape of the healthcare system. I don't know if I made myself clear. Do you want?
Yes, thank you for your question. Well, currently, since I am a teaching assistant at the University of Pristina, Medical Faculty in Physiotherapy Department, we are also changing our curriculums of the programs, and we have currently changed and included 2 other subjects that are related to physiotherapy in primary healthcare. So now we are introducing to our students the role of physiotherapy in primary healthcare and the specifics that they have to need for basic studies, so they can be more informed and educated for this system of for providing physiotherapy in this level of healthcare system. Also, we are conducting Master of Science in Physiotherapy. Also, there is included another subject regarding physiotherapy and healthcare system. But meaning in the general aspect, in the future, also we are requesting and advocating for specifics in physiotherapy, so specialization in different fields, and also primary healthcare will be and is our primary goal to be included, our physiotherapists to be included in physiotherapy in primary healthcare. Since this is very important, not for our physiotherapists to be more employed within the public healthcare system. Also, this is very important for patients, because they don't have access in physiotherapy only in the second and tertiary healthcare system. So they have to travel a lot to be on a waiting list and to gain their physiotherapy session. So who has their financial costs, they go directly to private sector, but there is a huge number of patients that need urgently to be to has access in primary health care. So there can be a more broad spaces, so where they can access physiotherapy service. We have a lot of work to do in this direction. We are working, and I hope we will achieve it.
It seems that you are going on the right track. Well, thank you, Arnor. I believe that this presentation, the 3 presentations, were great, and they capture all the heterogeneity that the survey was trying to show. And Gunnlaugur, you say that physiotherapy in primary healthcare in Iceland is it's new, and it's from 2011. It's actually very recent, but I believe that you are going steadily on a good path. And you said something that is interesting, because looking into your country, everything seems great. And you are saying that you have a shortage of PTs as a workforce. Are you I don't, not you, but is there something like a plan to try to tackle this issue?
Thank you for the question, Adérito. Actually, I was at this meeting just yesterday, and then there was the Minister of Education, University Education, and there is a plan, yes, to increase the numbers of healthcare professionals through the universities. And right at this moment, and both yesterday and today, we started working on what's the English word for it? how many physios we would need according to the governments, how they see the future. So we are basically in our first steps to try to make a plan and a vision about it. And we know there is a governmental emphasis on increasing healthcare professionals, and actually they already just a few days ago they were talking about that they increased the positions here in the University of Iceland for physicians from 60 to 75 next year, and from 75 to 90 in I think 3 or 4 years. So we are looking into the same things here.
Great. I think that's important, because
Yeah.
can we be talking about increasing the visibility of physiotherapy in primary healthcare if we don't have workforce to get them there? And also, this is also an issue in Ireland, Fran. If I heard correctly, the problem in workforce is also an issue for you. And are you planning something in Ireland to trying to tackle this as well?
Yeah, I was writing down, must get in touch with you because we're looking at the same thing. So absolutely. So our workforce planning is projected that by 2032, we need to increase our primary care workforce of PTs by 58%. It's like, how are we going to do that? So the Department of Health recently announced that they were going to increase the number of healthcare professionals, but the universities, we've got 5 universities delivering 7 programs. And the main limiting factor is trying to find the clinical placements for the students. We really struggle to find, I'm sure everyone's the same, there's a requirement for physios to complete the 1,000 hours, and we really struggle to find those placements. So it's a real chicken and the egg kind of scenario at the moment, because the workplace, the healthcare settings are saying that they can't facilitate more placements because of the staff shortages, but we can't increase and sort out our staff shortages until we can recruit and we can increase our number of graduates. So it's a piece of work that's being done, but at the moment it's quite a stumbling block. Just on a personal note, I'm actually busy doing a thesis, and I'm looking at the capacity of how we can increase capacity of practice education placements within the healthcare setting. Absolutely looking at this exact thing. How can we increase to enable to be able to increase our workforce? So I think we could all learn from each other on this one for sure.
And Arnore, I'm sorry, but what about in Kosovo? Workforce for physiotherapy, is it enough? Can you tell us a little bit more about that? About the amount of physiotherapists that are able or can be able to work in primary healthcare setting? Of course, I know you are working on creating the need, but do you think that the number of physiotherapists that are already there in Kosovo, they will be able to provide an answer for healthcare need in primary healthcare specifically, if they are needed to?
Well, the number of physiotherapists is growing yearly, and we are looking forward, and we are implementing some within the chamber some specific initiatives if the primary healthcare goes within the law, so we can make some specific trainings and specific lectures and informations, because we have continuous professional education. So we are planning to provide to our physiotherapists some basic knowledge for them that they didn't have any information about specifics on primary healthcare. Besides that, all our physiotherapists would be eligible to work in primary healthcare, and they can develop within time in more specific details about the physiotherapy in primary healthcare. So they are eligible to work in primary healthcare.
Great. Thank you, Arnore. Thank you.
You're welcome.
Thank you.
Thank you.
I had just had a reflection with about what Arnore was telling before, that if the structure of the secondary and tertiary care and rehabilitation in it is very strong, it's hard to advocate for the physios outside it. In the primary healthcare, for example, it's like a burden. Everyone thinks that you're trying to steal something from them. So I think it's very important. There's a lot of good ideas that we can take from each other. I had a question for Gunnlaugur, for you. How can, like, the physio, now the patient goes to the GP and the GPs refer patient to the specific physios, right? The ones who are in like a primary healthcare center?
They can refer them, yes, to them. But then again, we only have like 26 physios in 6.6 full-time jobs positions. So yeah, like I said, we're just we're taking baby steps in that way. But the referrals are to the private practitioners within the private system, which it's again publicly funded. So and this is physios within the primary care, they can also refer to private practitioners.
Mm-hmm. And then the salary comes from the, it's like from the clinic. The physios are as employers in a clinic. They don't work.
The physios in which are at the primary healthcare clinics, they are employees, yes. But then again, they are not for treatment. It's maybe 1, 2, or 3 visits mostly, and yeah, it's mostly as a diagnostic and first step in the process. So if they need long-term treatment or treatment more than that, then it's always to the private sector.
I have one question to the 3 colleagues that are currently in the panel. So from an advocacy and policy perspective, why do you think that physiotherapy needs to be in primary care alongside with the other professions? Yes, Fran.
I'll go. I told you I talk a lot. I think if you look at the demand on the healthcare systems, and if everything is kind of shifted to acute kind of settings, the acute settings, there's demand, there's over demand on them, but the distance for people to travel, the waiting lists for them to get in, the access to the services, when so much of that care can actually be taking place within primary community care, closer to the person's home, it's reducing the burden and the stress for the patient. You can really, like, physios are just delivering such high quality care close to the person's home. I think it's just so fundamental. Yes, it is like, if we look at and Arnore kind of commented on it in terms of the students and introducing the curriculum so that the students kind of are capable and feel competent enough to go and work in primary community care. Even within Ireland, we have majority of our placements still within acute, so we're still struggling to get that shift of students into primary community care so that they feel comfortable and competent to go and work there, and without having a placement they're not going to go. But I think it's just so important for the profession, for the patients, for physiotherapists, for us to be delivering excellent care within primary care. Yeah. So I got a little one asking for things. Yeah.
Thank you, Fran. Gunnlaugur or Arnore, anything to add or to concur?
Yeah, thank you, Fran. I think it's pretty much summed what probably all of us were thinking. I think it's also just about this, like you mentioned, it's about accessibility and accessibility to the right care at the right time without cost. And there are so many there are so many ways that point to the importance of accessibility. And like you know, Tim, we recently made a report about the effects of accessibility to private practitioners, which was made in 2017. And we've been looking into it according to new registrations on disability and things like that. And we are actually seeing we are seeing indications of good results of increased accessibility according to cost with new registrations for disability. So yeah, for me, it's mostly about accessibility for everyone.
Yeah, Tim, thank you for your question. As I mentioned previously, the need of physiotherapy in primary healthcare in Kosovo, it's primary. It's first regarding the accessibility of patients to the physiotherapy in to not to be included in this waiting list in the second and tertiary healthcare system, to reduce the financial costs of their treatment, because if somebody is on a need to do physiotherapy, if he cannot wait on the waiting list, yes, he must go to the private sector. So this is a financial implication that patients in Kosovo are facing that. Also, this primary healthcare will definitely improve the quality of physiotherapy, and including that on the educational system, this could be achieved. Also, the main fact that physiotherapy must be included is that our country must be standardized, must be in line with other European countries. Maybe after some years, going to the structure that Fran presented to us and other colleagues. So that's it. My question, my answer.
Thank you so much to three of you for answering my question. Līva, back to you.
Okay, back to me. Thank you very much for joining. I think we can summarize everything up, and I think we can continue with this at the general meeting because there are more and more questions and ideas where we can go and what we can give by sharing our stories. I don't know. Thank you very much all for your time and effort and your being here at the evening. Tim, would you like to?
Well, I will just echo your words, Līva. Thank you, Līva and Adérito, for leading this session. Thank you, Gunnlaugur, Abnore, and Fran for providing us with your testimonials. And thank you to all people who engaged and who listened to the webinar tonight. And as explained at the beginning, the recording will be made available afterwards and will be put on the region's YouTube channel. And keep an eye on that and of future notice by our Secretary General for another webinar from our group or other groups. I bid you all a very good evening and see you guys soon. Bye-bye.